Okay, I think I'm live. Here we go. Okay, so I'm gonna do a video about just my thoughts on pre-op assessment. Um, so as a cath lab nurse, um, you know, when you're when you're medicating, right? You're the circulating nurse. You're going to be managing the sedation. You're going to be managing um, the medications they need intraoperatively. So if you're anticoagulating, I feel like I'm looking at myself in the mirror and I'm just tripping. All right. So yeah, so intraoperatively, you're managing their anticoagulation if they're going to be getting stents or we're doing some kind of work. Um, we're also giving doing the hemodynamic management. So if their blood pressures are not working properly for some reason or any vitals are off, you're kind of the one that's going to be doing it. So you do something like a pre-op assessment. So I thought I would just give my thoughts on how I do a pre-op assessment. So, and I haven't really prepped for this. I just thought it'd be fun to come on here. So again, this is just how I do these videos. Um, yeah. So like, of course. So I'm gonna be like, just go to basics. So you want to get their name and you want to get their birthday, right? You want to make sure that that matches who you're supposed to be doing the cath on and what room number they're in, right? Because you got to go to the right room. And then you want to check their allergies. You also want to check their weight. You also might want to check their height because you want to know proportionally what is their weight to their height. Because someone who's 100 kilos, if they're 60 inches, it's kind of a problem. But if they're 72 inches, it's not a problem. So you want to get the height and weight, right? So those are like some basics. Then you want to start kind of going, down the line. Lower than recommended. Open widget. Oh, look at this. Hold on. I don't know what I'm doing. Let's see this. What's going on? Lower than recommended bitrate. We recommend that you use a stream bitrate of 4500 kbps. Man, I wish I knew what the heck I'm doing here. I don't know what I'm doing. All right, that's fine. I don't know. I don't know. Ugh. Yeah. So you get the basic demographics, right? You check their allergies. You check their room and name and all that stuff. Then I will check their vitals. We'll see what their vitals have been trending. How many blood pressures do we have? Have they been here? How long they've been here? They've been here a couple of days, or they've been here for 5 minutes. So get a blood pressure, get a pulse. And oxygen saturation, how much oxygen they're on. Those are kind of the big ones, and their respiratory rate. I sure you want you want you want to make sure they don't have a temperature too. I mean, that's helpful. But that's going to come with your vitals. So you check your vitals. You want to make sure you have IV access. So if they've documented, someone else has documented they have an IV, you want to confirm they have an IV, and it's in the right spot, hopefully. Um, because if you're going to be doing a cardiac cath through the wrist, right? If they're going to be accessing the wrist, and you have a IV that's like right here, that might be a problem for your sterile field. When you go to clean the wrist off and access the wrist, you might be having trouble getting access to your IV. So you want to make sure you have good IV access and that it's in the right location. Kind of important. Ideally, you'd have two IVs too. You want to make sure you have two IVs. One to push, ideally one to push code drugs, or one to bolus meds, and one to run drips on. If you can't, one's fine, but ideally you want two IVs accessible. So I'll check my vitals, check my IV, see if I have an IV. We'll check the labs. So labs specifically that I'm going to be looking at, I want to look at their white count, see if it's out of whack. Because do they have an infection, and is that something we're concerned about? Um, because you can have, you know, if they have an infection and they're in heart failure, that's no good. So you just want to be aware of those kinds of things going into the situation. Um, you want to check, of course, you want to check their RBCs and H&H. So you check their red blood cell count, and you want to check their hemoglobin hematocrit. You want to make sure they have enough oxygen carrying capacity. So if they need blood, give them blood. If it's high, they're dehydrated. Give them fluids. So yeah, so we'll check that. You want to check their platelets too. I mean, as long as platelets are fine. Um, if they're having a PE, you might notice their platelets might be super high, maybe. It might be low. Who knows? So you want to just see, are their platelets within range? You want to see this stuff because you're putting very large catheters in arteries, and you want to confirm that they're going to be able to, you know, handle that and be able to clot off if they, when we need them to. And you want to make sure they're not going to be hypercoagulable. So if they're, if they are, their um, platelets are like 500 or 600, you're like, what the heck is going on? You want to make sure that they're not hypercoagulable. They're not going to be having clots. You're not going to have clots going on in the middle of the case. That's not good either. So those are a few things. What else am I going to like? PTINR. You want to see if they have a good PTINR. I mean, ideally, sometimes you don't get a PTINR, but a PT is a prothrombin time, and INR is an international normalized ratio. And both of those things, you want to check them, make sure that they're within normal limits. Or if they're anticoagulated, that they're not too anticoagulated, they're not going to bleed out. So INR should be between 1, like 0.8 and 1, 1.1. If they're on some kind of chronic anticoagulation for AFib or something, maybe 2 or 3. If they have a valve, if they have an artificial valve, maybe 3.5 might be a little higher. But if you're seeing an INR of 7, hey, that's a problem. You might not want to cath this person, or you might want to reverse them before you cath them, or you might want to give them some, FFP or something. You might need to do something to reverse, or counteract that. Ideally, you would, if you can, you want to wait. You don't want to just cath someone with INR 7. If they're having a STEMI and it's like a big deal, you might want to reverse them or put on FFP, or I don't know, talk to the doc about what he wants to do. So that's another thing you want to look at, PTINR. What else? You want to look at a potassium. You want to make sure the potassium is normal. If it's high or low, that can cause ectopy, and that can be a problem when you're, you know, when you're doing stuff in the coronaries and you're throwing catheters into the ventricles, or you're taking a right heart cath and you start throwing, a Swan Ganz catheter into the right heart and into the pulmonary artery, you're going to have, if they already have ectopy or they're excitable because their potassium's off, and then you cause more excitation, you just can have more problems. So you want to make sure the potassium's fine. And if not, make a note of it. Make sure they haven't had any ectopy. So that's another lab I want to look at. Also want to look at their kidney function, because when you give contrast, it's all, it all goes out through the kidneys. So you want to make sure their kidney function is normal. If their kidney function is not good, another thing is if you're going to be fixing something, meaning you're putting stents in, and you use a medication called Angiomax, which is bivaluridine. It's a drip that is like heparin but way stronger. Kind of acts where heparin acts, but it also acts in other spots. It's really good medication, but if you're going to be giving them that, you want to make sure the kidney function's good. So those are a few things. What else do I want to look at? Glucose, what's their sugar? Make sure they're not like in DKA or anything like that. Their sugar's normal. If you can look at an echo, that's great. Look at an echo because you want to see their ejection fraction. Somebody with a really, really poor ejection fraction means they have systolic heart failure. If they have systolic heart failure, that means they can't squeeze. They don't have a good squeeze on their LV in their left ventricle. If they don't have a good squeeze, they're not circulating blood. They have a really bad cardiac output. The drugs you give them are going to take longer to clear because you're not pushing fluid through your liver. You're not pushing blood through your liver. You're not pushing blood through your kidneys as fast. So things are going to metabolize slower if your cardiac output sucks. Yeah. So also be aware of your Well, I'll get into that later. So, yeah, so those are some labs. What other labs? Let's see. I'm just trying to think of when I'm looking at my screen, like what kind of labs I look at. Um, I mean, those are kind of important ones. I think there's other stuff to look at too. You know, if they're on happen drip, you want to see what their um, you want. I mean, PTINR. That's fine. APTT. That's just another one. What else? Anything else? You want to look at an EKG too? See what the EKG shows. Are there ST changes? Do you have like new bundles? Are they in a regular rhythm? Is there P waves? Are they in a fib? Right? Are they tachyarrhythmia? What's going on? Do they, if they have ST elevation, where's it located? Right. So you want to look at all that stuff. What's QT? All that good stuff. Are they having ectopy? Are they paced? You know, you look at all that stuff. You look at an EKG, make sure you understand where we're at with the current rhythm. Um, Echo, EKG. If they got a CT of the chest, you can look at that too to make sure there's no dissections, um, no aneurysms they can see, no PEs. So CT of the chest. Those are some labs and diagnostics you're going to look at. Um, so as we continue on in our preoperative assessment, you want to see how much oxygen they're on. You want to see, um, you know, if they're intubated, what are their vent settings? You know, what else? What else? What else are we looking at? So we'll look at our MPO status. When's the last time they had anything to eat? What medications are they currently on? So did they get any anticoagulants today? Um, you know, you want to see if they're on taking. You want to you know reconcile their meds. Make sure you see what their home meds are. Are they on any long-term anticoagulants like warfarin or Xarelto or whatever? Um, if they are, did they take it today? You want to see if they are already anticoagulated, if they're already on Plavix or whatever. So some kind of oral, DOAC or whatever you want to call it, direct oral anticoagulant. So, or you want to check or an antiplatelet if they took aspirin. See, and if it's a stem, you want to make sure they got like 324 of aspirin. Uh, that's another big thing. So see what meds they got. Check their meds. Are they on any pressors at the moment because they're losing a pressure? Are they on any inotropes? Are they on any like a heparin drip? Are they on a nitro drip? What kind of medications are they on or have they been taking? So you want to check that too. Let's see. As we go down the list in my head, check an ASA and a Malampati. So generally ASA is anesthesia. What is it? Severity, no, anesthesia, no, American Society of Anesthesia. ASA is American Society of Anesthesia, and they have a score between 1 and like 6, and 1 means you have no problems, and a 6 means you're dead. And usually your patients fall between a 3 and a 4 generally. If it's a 3, they're like chronically sick. If it's a 4, they could die at any moment, and if it's a 5, they're dead and we're doing CPR or something like that. So generally, you want to get an ASA, and a Malampati is just a general score. Just it's just you have them open their mouth and they stick their tongue out. And I've mentioned this in another video, but I'll just do it again. Ah. So you can see you can see the tonsils. Ah. You can see like those lower tonsils in the back there, and that is a 1. And so if it looks like, let's see if I can do a 4. If it looks like that, that's like a 1. So depending on where it lands on that will help you kind of decide how difficult of an airway you're dealing with. Um, so that's another thing you want to look at. You want to make sure you got a consent signed. That's another big thing. So when you get to the floor, make sure you have a consent that says, we're doing a cardiac angiography or whatever, and that you have it signed. It's dated, today, or at least within the last 24 hours, ideally today, and it was witnessed, and that all questions are answered and by the patient. And then what else? Let's see. You want to check if there's a history of contrast reaction. you want to try and get an idea of their heart failure. So if they have, um, if they have diastolic heart failure, or if they have a preserved ejection fraction with their heart failure, how severe is their heart failure? Are they able to lay flat on their back, or do they feel like they're drowning because all the fluid backs up in their lungs? So you just want to be aware kind of how the severity of their heart failure. You want to see if they've had any contrast reactions in the past. And if so, you want to pre-medicate with like Benadryl and Pepsid. And why would we? So generally, I will, um, if they need to be pre-opt, we'll generally give 50 milligrams of Benadryl IV, 20 milligrams of famotidine or Pepsid IV. Both of those, Benadryl's H1 blocker, Pepsid's an H2 blocker that hits two different pathways of the histamine release and helps prevent any reactions from occurring, lowers the immune response from the contrast. So you're going to give you want to make sure they haven't had any contrast reactions. Um, what's some other stuff? Oh, trope. You want to check a trope, like a trope. You want to troponin, see if their troponin is increased. If they have it, you might want to look at like a D dimer if you're concerned about clotting issues. To see if they're actively clotting. Um, Let me see. I'm sure there's other stuff. I guess just off the top of my head. So what else? What else will we look at? We'll look at like, is the patient morbidly obese? Do they have obstructive sleep apnea? Do they use a CPAP or a BiPAP at home? Do they have asthma or COPD? All these things are really important because that's going to help us determine how we are going to manage their oxygenation and ventilation. So if this person generally is on 2 liters of oxygen, bled into a CPAP at night when they sleep because they have really bad obstructive sleep apnea, we're definitely going to need that patient if we're going to be sedating them and giving them medications that make them sleepy. We need to get them on that, right? So you want to see if they have that, and if not, we need to get it to them. So you maybe want to involve RT. If they have an ABG, that's another great thing to see, with a lactate. So you want to check an ABG if they have it, just to see what they're, how they're oxygenating, if they're acidotic, basically how their body's compensating with the disease process, if they're having any acidosis, and if their lactate is bumped because of heart damage or whatever, you might see a lactate bump. What else? What else? If they do drugs or they smoke, those are some big things. Smoking, drinking. So smoking and drinking are a little bit of a concern, because the medications we give for moderate sedation. We'll give midazolam, which is Versed, which is a rapid acting benzodiazepine, and we give fentanyl, which is a rapid acting opiate. The thing about smoking is that smoking upregulates your enzymes in your liver that metabolize Versed. So if you have an upregulation in the enzymes, you're going to break it down even faster, and the drug's just not going to work. You're going to give it, and they're like, I don't feel sleepy. I feel fine. You can give more. I feel fine. They're not going to fall asleep because their body is burning through, chewing it up, eating it up. They're not. It's not having it's not effective. It's not working. So you may have to go to different drugs, different medications. So you want to see if they smoke and they drink. If they drink, also, they're going to have a higher tolerance to this stuff because basically Versed is liquid alcohol or IV alcohol. It's just alcohol that this does the exact same thing to your central nervous system as alcohol does, but in a very small little vial, and very quickly. And it bypasses the liver, and it's not quite as bad for you. It's not bad for you. So, but it does the same thing alcohol does. So if they are drinking alcohol regularly, um, you want to be aware of that. So what else? And drugs can do that too. If do meth, or they smoke pot or anything. You kind of do cocaine. Any of these things, just be aware of that they're doing these things because it can have an effect on the drugs you're giving. They may need more of them. What else? What else would I check? You want to, yeah, I think I said check your age. You want to see how old they are. That's important. The older they are, you have changes in the body with your age, related to how you metabolize drugs and how you respond to drugs, and how much, physiologic stress you can tolerate. The older you are, the less physical stress you can tolerate. So what else? What else do I have to worry about? I don't know. Those are the things I think about. Those are the things we're thinking about. Those are some good things. Hmm. You might check if they're having, when you get to the bed, when you get to meet them, um, you want to see if they're having any chest pain or any kind of pain at all. And if they are, you would like use OPQRST, onset, provoke, quality, severity. What is it? Onset, provoke, OP, quality, radiate, severity, and time when it happened. You want OPQRST their pain, just so you have a good idea of where the pain's coming from, or you can get an idea of what's going on with the pain. Um, I think that's it. That's some stuff I think about. Yeah, that's pretty much it. I'm trying to think. Let's see, is there anything else? I feel like that's about it. I'm on call right now, so waiting for a call. Yeah, I don't know. I thought I'd make a little video while I'm on call and just hanging out. I don't know if there's I don't know if there's anything else. Anything else that's super interesting, with see details. What am I doing? I'm looking at this thing. Okay, whatever. Yeah, so I don't know if there's anything else uh, that I would worry. That you worry super important. Those are some really important things. You get a pretty good idea of who you're getting involved with. Another thing you want to do is read an HMP. That's a good one. So if you can read an HMP before you get started, that's like golden. Um, so that'll give you a little. So an HMP is a history and physical. So that'll show the doctor, the attending physician, maybe the cardiologist, maybe the ER doc, maybe an internal medicine doctor, whoever got a good feel of who the patient is. They're going to give you a past medical history. They're going to give you a history of present illness. When you read that history of present illness, it'll tell you the story. It might give you a little background. Get a past medical history on them. This person has CAD and CHF and diabetes and whatever. Came in today with chest pain, shortness of breath, and then so they'll give a big list of why they came in, events preceding this, what they have, what their current medications are, their social history, their surgical history. So if you can read an HMP before you go see them, that's like ideal. Um, Now, in the cath lab, everything's relative. So, like for instance, right now, if I get a phone call right now that there's a STEMI in the ER, we're behind the eight ball already. I got to get over there as fast as I can. And there might be an HMP, there might not be an HMP. I'm only 3 minutes away from my hospital, so I'm gonna get there I'm probably before anyone else gets there, and I'll probably get there before there's an HMP. There might not, the doctor might not even have written a note by the time I get there, and we're getting ready. So, you know, in a perfect world, get an HMP. If not, it's fine. Another thing you want to do is, if you're working in a cath lab and someone's coming in, maybe it's not their first time. And if it's not their first time, then and they've come to the cath lab before, then we already have information, right, on them. We have a whole, procedure log of the last cath. That's going to give us, their last EF. It'll give a roadmap of their current coronary anatomy. It'll say what medications they got last time. They're going to say the recommended bit rate. We recommend that you use a bit rate of 45. What the heck does that mean? I wish I wish I knew what that meant. Why don't I know these things? Okay, we're going to go like this. I'm fixing it right now, I think, maybe. 4,500. I don't know what that means, but I'm going to try and listen to them. Apply. Okay. I don't know what a video audio bitrate should be at. Okay, video. Okay, I don't know what I'm doing. I don't know what I'm doing. Okay. Whatever. Doesn't matter, I guess. Don't know how to fix that. Oh gosh, I need to take like a class on how to do this stuff. I've been doing it so long, I just don't seem to care if I'm doing it right or not. All right, whatever. So yeah, so roadmap meaning like what did their coronary anatomy look like before? Were there lesions? Were they fixed? What was the percentage of them blocked? Um, you also can look up because you want to know kind of how the procedure went. What kind of anticoagulants did they use? What what guides did they go up with? Basically what kind of wires they used. What do we need to pull for this time that are just hopefully going to work first try? We're not, fiddling around trying to switch out catheters and trying to find the right catheter that fits. Do they have grafts? You want to see if they have bypass grafts. So those are some things that you want to look at too. I think. Sorry, I'm reading this. I think that's pretty much like the most of the stuff that I'm looking at before we go see the patient. That's what I look at. Anything else? I'm just trying to think. I think that's it. I don't know. I guess that's it. So I guess I could either go offline, I can just stop this, or I can study. And then I can turn this into a study sesh. Because I've been studying like crazy last few days. And, just trying to, just be as prepared as I possibly can be when things go down. Because it's some serious business when things hit the fan. You just don't want to be behind the eight ball. Let's see. What am I studying right now? Studying a lot of stuff. Yeah, I guess I'll just study on my own. This is too much. All right, this felt good. That's what I'm doing right now. That's that's basically what I'm doing preoperative assessment. That's my basic preoperative assessment. So I think that's all I got. And if you made it this far, kudos to you. That's all I got.